Hello, everyone. Welcome to this webinar organized by the Global Network for Health in All Policies and Wellbeing South Australia. My name is Marianne Jacques. I'm a scientific advisor at the National Collaborating Centre for Healthy Public Policy here in Canada and coordinator for the Global Network for Health in All Policies. I want to start off today by acknowledging that I'm located in Montreal, Quebec, Canada, an age-old Indigenous territory, a place of meeting and diplomacy between peoples, and the site of signing of the Great Peace Treaty. I want to thank the Mohawk Nation for their hospitality on this unceded territory. So before we start the webinar, I also want to share a few housekeeping information. So please use the Q&A box to ask questions to speakers, or if you have any technical questions, please use the Q&A box to do that. We invite you to use the chat box if you want to exchange with every participant, if you want to share resources, or if you want to engage with other participants, please use the chat box to do so. Also, I want to mention that the webinar will be recorded, is being recorded, including the chat and Q&A boxes. So please keep that in mind when you're typing in your questions and comments. The recording will be available on the Global Network's website. And also, there will be an evaluation from this webinar, which will be shared by email after the session. And so now I would like to introduce Dr. Horacio Arruda, Assistant Deputy Minister for Health Promotion and Prevention in the Quebec Ministry of Health and Social Services. He's the chair of the Global Network. He's going to offer a few welcoming remarks. So Horacio, the mic is yours.
Okay, you hear me well?
Yes, we do.
Okay, thank you, Marianne. Good morning, good afternoon, and good evening, everyone. We are all around the world. That's wonderful. I'm very happy to be joining you today from Quebec, Canada, as the chair of the Global Network for this webinar. As we all know, health and well-being are influenced by a wide range of social, economics, political, cultural, and environmental determinants of health. This is why working across sectors is a key for improving health and well-being outcomes. In that respect, Health in All Policies offers opportunities to support multi-sectorial collaboration and address the determinants of health. The Global Network for Health in All Policies is dedicated to support Health in All Policies implementation and practices by sharing knowledge and supporting capacity building around this approach. Through our various activities, one question that often comes up is how to initiate and sustain collaboration with sectors outside of health in order to improve population health and well-being. Why working across sectors can be challenging, we know it. We are seeing various models around the world that can help address this challenge. Today, we have the opportunity to learn how our colleagues from South Australia have implemented health in our policies, and specifically how they implemented their public health partner authorities to sustain multi-sectorial collaboration. I will now hand it over to Lauriane Risborough, who is Director of the Health Promotion Branch at Wellbeing South Australia. Lauriane sits on the Executive Committee of the Global Network and will be the moderator of the webinar. Thank you.
Thank you so much, Horacio, and thank you to everyone online today. I see we have around 42 participants, and hopefully a lot of others have registered to watch the recording. But firstly, I'd like to acknowledge the land that I meet on today is the traditional lands of the Kaurna people, and I pay respects to the elders past, present, and emerging. So first up, we're going to have a 20-minute presentation by two of my wonderful colleagues at Wellbeing SA, Amy Priscelli, who's our Principal Project Officer, and Professor Katina Denisi, who's our Executive Director of Prevention and Population Health. So I'll pass on now over to Amy and Katina.
Hello all. I'm hoping you can all hear me. So just going to wait to see if Katina is able to, yeah, I can see Katina's in the process of sharing our screen. So I'd like to reiterate Lorianne and Marianne's acknowledgement of country. Those of us presenting tonight here in Adelaide, South Australia, are joining you from the traditional lands of the Kaurna people. But I also wanted to acknowledge that we're attending this webinar from locations all over the world, and that there are lands in all of those places who are incredibly important to the First Nations populations of those places. So I'd also like to extend acknowledgements to those places, and particularly to any First Nations people who are part of this webinar this evening. Next slide, please, Katina. So I just wanted to start by providing a quick overview of what Katina and I will cover during this webinar. So starting off, we'll build on some of that great background that Horacio just provided and talk about the rationale for partnership approaches, of which health and all policies is one that you're all very familiar with. We'll then talk a little bit about the history of the health and all policies approach in South Australia. Again, many of you who are online are probably familiar with South Australia's health and all policies approach, but I think it's really important to review the history a little bit, especially in the context of the governance and accountability associated with the approach in its early days. And then that will lead us into talking through the evolution of the health and all policies approach. And Katina will be talking through that, talking more specifically around South Australia has utilised a component of our public health legislation to develop and implement public health partner authorities and how health and all policies contributes to that. And then talking a little bit more detail around the governance and accountability, and then of course, evaluation and successes. Next slide, please, Katina. I think you might need to click. So just an apology as well. I didn't realise that there were some unusual animations in this template that I've used. So I apologise that we might have to click through it a little bit. So as you would all be very well aware, public policy decisions have the power to shape population health and wellbeing outcomes. Health and wellbeing outcomes are influenced by and are grounded in systems and policies that are both complex and complicated in nature. We know specifically that the social determinants of health play a critical role not only in shaping population health and wellbeing outcomes, but importantly, they also play a critical role in contributing to the inequities that we see across and within populations. So we see this across a range of indicators, and of course, the impacts of COVID were not immune to these impacts as well. And we know that the social determinants and the broader determinants of health and wellbeing also played a critical role in COVID outcomes and were a critical part of COVID responses across many countries as well. So in order to generate effective policies that protect and promote health and wellbeing, partnerships across sectors are not only beneficial, but they're also essential. The health sector simply can't act alone to affect change in these areas because we don't have the policy levers or the remit to do it on our own. And when we talk about sectors, I guess we mean the different sectors in terms of the areas that are responsible for the policy areas of the social determinants of health, but we're also talking about sectors in terms of different levels of government. So looking at national, subnational and local levels of government, depending on your country's government structure, and also looking at the critical role of non-government organisations and, of course, our academic institutions. So using co-designed strategies to inform the approach, public health professionals can facilitate and support policies and systems to be designed, reshaped or retrofitted to support good health and wellbeing outcomes. And I guess the last point I wanted to make here was that partnerships also provide opportunities for us in the health sector to work so to work better. And I was reminded by a colleague who works within the health sector at our National Population Health Congress just last week that the health sector is still really seen as a big spender, and the COVID response, I think, definitely contributed to that view, of course. And we're also still, I think, often seen as health imperialists. So working in true partnership also provides us an opportunity to really demonstrate our ability to work in a way that's more diplomatic, and health diplomacy is critical to that. So next slide, Katina, please. Thank you. So a very brief history lesson 101 of health and all policies in South Australia. So I think most of the people online will be very familiar with Professor Ilona Kickbush. And Ilona was a thinker in resident in South Australia in 2007-2008. So she came to South Australia, looked at the way that the health sector was working, and looked at the different opportunities that existed within the policy arena at the time to look at how we could be doing things differently. And the key recommendation arising from her residency was for the South Australian government to consider developing and implementing a health and all policies approach for the state. So that is exactly what we did. So the approach was led by the health department at the time, but really importantly, there was a strong mandate and strong support from central government, so our local department of the Premier and Cabinet. And I guess the other key thing that supported this approach in terms of having that central government mandate was also the existence of a state strategic plan. So we were really lucky in 2008 that the state had a high-level plan that included a range of indicators across a whole variety of different policy areas. And Professor Kickbush very cleverly recognised and articulated early on that strategy really represented a blueprint for action on the social determinants of health. There was a range of indicators across all different policy areas relating to the social determinants of health. And critically, in relation to that strategy, there was a higher level of accountability and buy-in, in that chief executives were responsible for ensuring that those targets within that strategic plan were met. And it became a priority, I guess, for all agencies across government. So that really provided us with a clear opportunity to, I guess, road test, to trial some approaches to implementing health and all policies within the state. So we worked initially with a number of early adopters, so willing partners, other areas of government who were interested in working in partnership with the health department to collaboratively progress policy areas of mutual interest. So from the very beginning, there was a strong emphasis on looking for opportunities to undertake a co-design process and where mutually beneficial outcomes could be realised. So out of that process, we developed what we referred to as the Health Lens Analysis Project, and that drew very strongly on the principles of a population health approach. So there was an early negotiation phase where we would clearly articulate and agree on what the policy area of interest was with the other sector and what the expected outcomes would be for them and for population health and wellbeing outcomes. We would then partake in a joint process of gathering and analysing evidence to inform our approach, and we would develop a series of recommendations that would then be put to the executives, the decision makers in both the health sector and in the partner agency. So I guess out of that, not only did we develop a process, but we also developed some governance structures, which I guess is what we wanted to focus on talking about today, and Katina will be talking about in a moment. So in terms of governance for this work, we had a high level of support and accountability provided by our relationship with central government. We then had an internal project, I guess, governance structure that had the responsibility for identifying potential policy areas that could be jointly explored and for also prioritising those for action, recognising that we couldn't work on everything at once. There were about 54 targets in the strategic plan, so we needed to be strategic in terms of which one once we opted to work on first. And then each individual health lens analysis project also had its own individual governance structures. So I just wanted to, I guess, touch on those really quickly because in 2011, we had our new Public Health Act introduced, and the enactment of that commenced in 2013, and that really changed how we were able to realise health and all policies in South Australia. So I'd like to hand over Katina now to talk you through what that evolution looked like. Thank you, Katina.
So I'm now going to talk through the evolution part and spend a bit more time focusing on the Public Health Partnership Authorities component of it. But I do think it's important to say that given the time of inception of health and all policies, there has been adaptation of the approach. Here we're talking about a bit of an adaptation that came with the opportunity of new public health legislation, but equally with changes of government or changes of priority, there has been a requirement to kind of shift as we go. The fact that the health and all policies approach in South Australia has been able to adapt is really testament to the value of the approach and the value it's provided within South Australia. So the legislation, as Amy has referred to, was commenced in 2013, and what it brought with it was this concept of a public health partner authority, which I'll just go into more detail. So yes, under the Act, we have this opportunity to create a public health partner authority. And really what this is focusing on is the core of health and all policies, and that is we're looking to achieve mutually beneficial outcomes across the different agencies that are involved. It does draw on the principles of South Australia's health and all policies approach. So for example, our public health partnership authority agreements are dedicated formal agreements which outline common goals to work together to achieve and provide the impetus for collaborative action between the health sector and other agencies. So we currently have over 20, I believe we have 24 formal partnerships now under our Public Health Act, and they're across a range of partners. So we have policy partners in government, in the non-government sector and academic institutions. And also obviously very pleased that we have two of our partners representing us today in the next panel. So this is a slide representing the different partners. I believe all 24 are here. It's very busy. But really what I wanted to draw out here was that we cover a really broad range of policy areas with our various partners. So for example, we're working with partners on food security, also on improving and protecting urban green spaces. We have partnerships that look at strengthening the early years system for young children. And we also have partners that are supporting us in developing our strategy and working through our cultural determinants of health program of work with South Australia's Aboriginal population. So as we've been talking about, really, this is based on a co-design process with co-benefits. And really, this is a very important part because we do take a focus on the policy priorities of other government agencies and look to how we might be able to value add. This is it is not difficult to find policy priorities in other government agencies that supports the social determinants of health. So for example, when we're working with education having the literacy and numeracy of students as an important outcome, that's also important to us. So this is actually not a difficult thing to do when working with other agencies. So we do have a multifaceted role. So it's not always that we're there to lead the partnership or that we're there, as I've said, to promote a pure health agenda. Sometimes we take the role of introducing partners to each other. We might take the role of supporting the process of partnership development. So we really do see this as quite a broad, I guess, platform, if you like, which includes a range of activities that we might undertake under the guise of partnerships. Now, our agreements are signed off by the Chief Executive generally of the other agency that we're working with, and they are voluntary agreements. So they're not legally binding, but what we do in these agreements is that we're really clear about really what we want to achieve as value in the partnership itself. So while, and I think that's a really important point, because it's not really just a matter of adding one agency's activities to our agency's activities and seeing if that makes it better. It's actually looking for kind of a synergistic, a coming together value where we wouldn't be able to achieve them separately. So now I'm just referring here to the governance and accountability pillar of the new HiAP model. So this is really talking about the governance, which is a core component of the public health partnership agreement process. So we do actually negotiate, as well as negotiating, for example, the goals of our collaboration, what our deliverables might be, any resources that we may commit. And they're not always going to have resources committed, but sometimes we do. So we will agree on all of these things, but we'll also agree on how we will govern the partnership. And that's a really important thing. And that will be flexible, in fact, to the context. And sometimes as well, even with the same partner, we may have differing levels of emphasis over time. And so this will depend on, what might be the government's priorities of the day, for example, which might lead us in one direction more than another. So we do generally have a two-tier governance structure, except sometimes when we're working with smaller NGOs. But that's where we might have an executive structure where we've got executives and perhaps other key stakeholders who might be part of a strategic advice or decision-making body. And then we also have a project implementation group, so a more operational group who will do the work. And this will be brought to the executive group from time to time to check in. And that's really an accountability mechanism as well as an authorising environment. So these public health partnership agreements are and the authority are designated in the South Australian Government Gazette. So they're actually gazetted by the Minister for Health and Wellbeing under this Public Health Act. And so in terms of evaluation, one of the things we do with our public health partner authorities is we do report progress for each of these agreements and authorities in our 2-yearly Chief Public Health Officers report. And that really is a kind of very public accountability mechanism for us. But we do take evaluation of this very seriously. So there certainly was a formal 5-year project that looked at evaluating the earlier versions of health and all policies, and we're looking to extend that now, revisiting that evaluation and seeing whether we were able to I guess, adapt and mould and improve, as of course is the purpose of our evaluations, is to see where we've got room for improvement. We also, apart from the evaluation of this model of the process of working, we also evaluate individual projects because we are looking to see that we're meeting those goals that we've set in our agreements. But yeah, so it's really quite a layered approach to evaluation. And I will now give an example of a project that we've been working with for many years in partnership with our Department for Correctional Services, and you'll hear from John shortly. And I'm definitely not going to go through all of this with everybody, but this is an example of the sorts of evaluations that we might do across an individual partnership agreement. In this agreement, we have multiple areas of focus, but this one here that I'm presenting now is on the nutrition, so the food that's available to prisoners across South Australia. And this has taken, and I won't steal John's thunder for later, but we've basically worked together, and we continue to work together to implement across all of the prisons in South Australia. But we've really moved it from the nutrition available to prisoners, where we had 7% of the meals were considered to be green. Now, I'm not sure if that translates to other countries. We basically have a ranking system of green, amber, red, like traffic lights, green being the healthiest sorts of foods that we would like to have as a majority. So that's where things started some years ago, but then more recently, after the implementation of this project, that's gone to 71%. So, and prisoners, that we've also introduced prisoner choice with a meal, which has improved prisoner satisfaction. So this is an example of us working with one of our agencies and the sorts of evaluations that we do to hold ourselves accountable. So there are other parts to our Public Health Act that we have not yet really explored the potential of. One of those is our Part 8. We have a section that's dedicated to non-communicable disease, which is obviously not all that typical in the scheme of Public Health Acts. But it provides an opportunity for us to develop a code of practice that will be called up under the Act. And of course, in doing so, we would be using the principles of health in all policies and co-designing with the relevant industry or body or group for whom the code of practice is intended. Now, of course, it can take an alternate view and not have it be a co-design process. And I guess it really does depend on what type of code of practice we would be implementing as to the level of appropriateness of engaging with, I guess, the end users. Another example that it probably warrants raising is that under the Emergency Management Act, which is clearly not a Public Health Act, but it is the act that was used within South Australia through COVID, because it provided the requisite powers to control the pandemic. We did find that under that act, we did have very rapidly developed partnerships which were very effective. So in this instance, I don't know if it's exactly the act that was the facilitator or if it was really that the individual universal goal that many agencies and people collaborated around. So I think that might be the last slide. Yes.
Great. I just want to thank so much Katina and Amy for your fantastic presentation, and hopefully John would touch on some of the things, the evaluation from one of the prisons, Mobilon Prison here in South Australia. So I'm now going to, it's a Q&A session. We have around 5 minutes for questions and answers before I invite the other panelists, Tracy and John, to join us. So as Marianne said at the beginning of the presentation, there's a Q&A box there, and I see we've got 11 more people online as well too, which is fantastic. So if you can start adding your questions into the Q&A box, and then Marianne will read them out. But I'll first start with a question while that's happening, and I'll direct it towards you, Amy. One of the things I know obviously Wellbeing SA is doing is looking at a strategic approach across the public health partner authorities. And I was wondering if you can just tell us a little bit about that review and what are strategies in place to put that approach in place.
Sure. Thank you, Lorianne. So I guess one of the downsides of our public health legislation and the way it frames public health partner authorities, I mean, there are pros and cons to this, is that the legislation itself isn't prescriptive in terms of who can or can't be a public health partner authority. And it's also not descriptive in terms of what the process is for establishing and implementing public health partner authorities, aside from the fact that, as Katina mentioned, the Minister for Health and Wellbeing does formally gazette the partnerships. So I guess from 2013 up until this point, in terms of implementing public health partner authorities, we've really leveraged off of the known success of the health and all policies approach in terms of its processes and practices. And we've also leveraged off of a lot of the existing relationships that we had in the health and wellbeing sector with partners in other sectors. But we recognise, I guess, now that we're at a point where we would like to move on from developing those partnerships in a somewhat ad hoc way and really take a more strategic approach in terms of how we identify potential partners, looking at things like, if we're wanting to really make a difference in the social determinants of health and wellbeing space, who do we as a health sector need to be partnering with to influence changes in that space, and to prioritise our partnerships and efforts in those areas. And obviously part of that is also looking at what the government priorities are at the time. And we are in a position now where we don't have something like the whole of government state strategic plan, but it's quite possible that something like that will be developed in the near future. So that might also provide a framework for some of that thinking. So we're looking at developing that strategy now, doing some internal and external consultations, and then launching or releasing a strategy early next year, February, March. Don't know if Katina wanted to add anything to that.
No, she says, but we do have some questions in the box, which I can see as well. So the first one's from Elizabeth Davis, who's asked, and Katina, maybe I'll throw this to you. Are there multiple partners in public health partner authorities, and are they time limited?
Well, thank you for that question. So in answer to the first part, part of the evolution that we really didn't, I guess, have enough time to go into is that we at the inception, we really were doing the public health partner authorities as a one-on-one, so Wellbeing SA with another agency. Over time, we have adapted that to expand the public health partner authorities to include more than one partner. And part of the strategy that Amy just talked about is also in the coming short period of time is to look at how we do multi-agency partnerships. So that might be a collective, for example, around a geographic area, perhaps a regional area of South Australia, or it could be a collective around an issue. And we are looking to work more closely with our local government authorities. So we have a third tier of government in South Australia. And that will have that kind of expansive approach where we're trying to bring all the relevant people as it relates to whatever the issue that's being raised. So we are keen that that is part of the evolution, and that is also why we are planning an evaluation to run alongside it so that we can really see, what are those effective strategies to get in the multiple agencies under these sorts of agreements. And in terms of the time, well, actually our legislation doesn't provide information about a cutoff. So at this stage, once a group has become a public health partner authority, they are continuing as such under the Act. That said, the agreements that go with those authorities tend to be sort of 5-year agreements now, and they may lapse. And for some partners, where it's not a priority for action at that moment, the agreement may lapse, but the authority doesn't. But then we, can pick it up at any later stage. And we've certainly got examples of that sort of approach.
Great, thank you, Katina. Now there's a few more questions here. I might just do one now because it's an interesting one of working with First Nations people as well too. So maybe we can hold that on to the end because I know we're going to our time, Adelaide time, to 8:45. But I'll ask one more question and then we can move on to the rest of the panelists as well. So the other question is, and either Katina or Amy, you can answer this, is there different success rates between the partnerships made with government, NGOs, or academic organizations?
Amy, did you do a preference?
No, you can go first.
Okay. I am not, well, I will say that government agencies generally have more resources, and I don't necessarily mean this in terms of the kind of cash resources, but they generally have more people that they can put to the work. They generally have much greater policy levers that can have an impact on people across the state than do our partners. That's not to diminish, though, the value of different partnerships for different purposes. So, it really does depend on what we're trying to achieve, because in some instances, as an example, working with Aboriginal and Torres Strait Islander people, sometimes government is actually not the best partner. Because of historical issues with colonisation and ongoing trauma. So I think it really depends on what it is we're trying to achieve as to where the level of partnership and who the best partners are. Don't know, Amy, if you wanted to add.
No, I totally agree with all of what you've said, Katina. I guess the only other thing that I'll add was that initially for the first, cabs off the rank, the first few public health partner authorities that we developed, we were in trying to develop some criteria around who we wanted to prioritise as public health partner authorities. I guess we were looking for partners that had a really broad population reach, if not a whole of South Australian population health reach. So I think that probably in itself lent more so, not in all cases, but in most, to us partnering with other government agencies initially. But I think, like Katina said, now that we're shifting our focus to working more closely with local government and looking at issues that that impact differently or more so on certain subgroups of the population, I think that's where our partnerships with NGOs and also with the academic sector will probably, pick up a little bit more as well.
Right, thank you. Now I'll just move it on so we can get our other panelists to join, but I do see the other questions there as well too that we can get to. And I'm assuming if we can't get them to now, hopefully there's a way that we can respond to all other questions if we don't get a chance before this session ends. But I'd like to, Amy and Katina, to keep your cameras on. And if Tracy and John could turn your cameras on now as well too. So I'm really honored to have both John and Tracy here, who are two wonderful people to work alongside. And both of them are going to give a overview of their participation and experience with the public health partner authorities. And I'll probably start with John Strachan first. John's a principal advisor of the Defended Services of the Statewide Operations Department for Correctional Services for the Government of South Australia. So he'll give a 5-minute overview of his experience and participation. So thank you, John.
Thank you very much, Lorianne. So just to get started, I might just a very brief introduction into South Australia's prison system. So we're a very geographically spread system with 9 prisons across South Australia with approximately just over 3,000 people in custody at any one time. Like many nations around the world, and many, obviously, it's very seriously in Australia, there's a significant overrepresentation of Aboriginal and Torres Strait Island people in custody, or First Nations people, which presents itself with unique challenges, but also really unique opportunities in this space as well. We also know that the prevalence of things like chronic conditions and some fairly negative impacts around the determinants of health are much characterised by people who are in custody at any one time. And it starts to really open up a lot of thinking for us within the Department for Correctional Services around what is the role of a prison. Because we are very focused on ensuring that we improve healthcare, improving access to mental health care, disability services, rehabilitation services, and so on. And one of our biggest goals is improving the well-being of the people that do enter custody, and our primary target is preventing those people coming back. And interestingly, South Australia is leading the nation at the moment in terms of recidivism impacts with our recidivism targets and our rehabilitation programs. In terms of the public health partnership, I just really wanted to say what a tremendous opportunity and experience it's been for us in the Department for Correctional Services. And I think one of the first things I would say is it really fits and supports the principle of a whole of government approach to be able to support people with complex needs or with needs that sit outside of the individual agency in question. We know in the Department for Correctional Services what our impacts can be, what our role and function is, but there are so many things we can't do. And the Public Health Partnership Agreement has really opened up our thinking and our opportunities and our experiences to working with Wellbeing SA and the Public Health Nutrition team in terms of bringing a whole new expertise into something that we just had very limited skills in before we started our partnership in this particular space. I think something that's really been great around our public health partnership with the expertise that's come in is combining, I guess, a really strong platform for change. The evidence-based approach that we're bringing into what we're doing with our public health colleagues has really brought a very strong foundation to create that change. And for anyone coming in to work with us in a public health partnership setting knows how complex change is within a prison type of setting, because it's a unique environment where you have a combination of what we call prison officers, you have clinicians, you have a combination of knowledge and skill sets that sit across all of that is quite unique in its own way. I think what it's also been able to do for us is bring a very strong approach into evaluation, and I wanted to acknowledge the work that's gone into that, because one of the most important things is to measure the impact of what you do, and whether that's good or bad or whether it's successful or not. But the evaluation support we've had from Wellbeing SA has just really got us thinking in a very different way around how you can sort of do those sorts of things and how we engage that. And I think I just note some of the questions that we were presented with to think about. It was really interesting. The governance that Katina spoke about earlier is crucial to the success of a public health partnership. There's no question of that. And I know early on in our time, and I know a lot of discussions I've had with Lorianne in this space, is the key around success, effective governance and key points of contact. So from my perspective, we've been very fortunate to have had a resource from Wellbeing SA as a public health nutritionist who we've now embedded within my team, but also embedded across the prisons that we're working with to make the changes. That is unique, and it's fantastic to see the success of that role coming in and becoming part of our system, but bringing all the knowledge, skills, and access to information from Wellbeing SA. But we've also been fortunate to have established that operational working group that Katina talked about as well. So we've got that running very effectively, and we have regular governance meetings between myself and I guess Lorianne is my peer within Wellbeing SA. But then the outcome and the results of that get reported up into multiple pathways within DCS. So for us, that's our strategic performance group and our general manager group and our executive group. But we also have an executive meeting, an oversight meeting, which has the Deputy Chief Executive, which is my line manager, and obviously Katina from Wellbeing SA is the relevant executive there. So I think that's been a really key link into making sure it happens. The changes do happen. Correctional services are very much a chain of command system. So if we've got the right structures in place, we have a far greater opportunity to create impact for change as well. A couple of other really key points as well that I wanted to reflect on is having the expertise and the evidence-based approach coming in has really helped us in a highly industrialised culture that we have within Department for Correctional Services. And it's been really interesting for us to watch the evolution, I'll call it, of our industrial bodies and our industrialised staffing groups have really got on board with this process. So instead of it being a threat, using really good key engagement, evidence and change management, we've seen a real shift in that space. And for us, it's created a much greater opportunity for change. I'll just briefly for a minute touch on the successful implementation we did at Mobilong Prison. And I think Katina touched on some of those keys there. And interestingly, with Mobilong Prison being the first prison that we did this piece of work for, we've now got this wonderful engagement across all of our other prisons. I just absolutely can't wait to get started. And we know we can only do a couple of prisons at a time, but we've just already started to see the effort from the other prisons to start creating some initial change. And we're going live on Friday at the Adelaide Women's Prison for the second menu choice and improving the nutritional changes. But the interesting thing for us is they got ready before we started. So they started to make changes before we started, just through the triggering of the work we did in the public health partnership. And what we've seen is the sense of confidence and self-efficacy of our kitchen teams, noting we only have 1 or 2 kitchen professionals, the rest are prisoners who do all the cooking and work. They initiated a lot of their own changes to try and get ready, which we thought was tremendous in that space. Just a couple of key points though, with the evaluation. What we discovered was, prior to doing this, clearly our food was not up to a Australian Dietary Guideline standard. In that we have a very limited budget for food, but what we've learned is that we can do this in a cost neutral way with the expertise of the Public Health Partnership. And in modern government times, being cost neutral as much as you can is a great way to get really strong executive and ministerial buy-in as well. But when we did our work at Mobilong, we found that the 75% of the prisoners surveyed actually really wanted change, and they wanted the opportunity to improve their nutrition. Another key component was people want choice. So when you've lost people in custody, lose their civil liberties, and they have no choice. So what they were served is what they were served. And what ends up happening is that people put forward what we call value-based special diet requests. So someone might say, I'm allergic to tuna or I'm allergic to tomatoes. It's because they don't like them and they don't have a choice. What we've seen is a dramatic reduction in people expressing these value-based special diets with the provision of menu choice coming in. Menu choice is also, through our evaluation, highlighted a really positive impact on people's perception of recidivism. So when someone leaves custody, they're actually they actually do have to choose food. And we've, through the traffic light education system and the way that we prisoners order that through it's an online system within the prison, they've learned how to use the symbols that you would encounter in a supermarket to be able to make informed choices about their nutritional needs and what they wish to do as well. I think the only other thing I'll quickly sort of say as well in this space is there was great engagement from our public health nutritionists. It's been across both of the prisons we've completed now with the prisoner needs group. So it's like a consumer consultation approach, and the engagement and the education that's being provided in that space has been really positive for the people in custody who are wanting to make those sorts of changes as well. So there's a couple of other challenges that come with all of this, and one of the biggest challenges we face is portion control for prisoners. Food is seen as something that is very important to our people in custody, and we talk about managing the temperature of a prison, because if you take away certain things, you can get some very negative reactions from our prisoner group. But the way that we've done this in an incremental and slow and steady sort of way, and using this as an opportunity to provide education for people that healthier choices are really important, it's really having a positive impact on the prisoner engagement. And one great example was we have prison industries, and one of our industries is interesting is the food industry, and we've moved from white bread to wholemeal bread across the state for our prisons. Now that might sound small, but it's a huge, huge change for us. And from the prisoner side of it, they love it. They actually, because they think they associate with healthier eating and they like the taste of it, but it would not have happened without the public health partnership. So I guess that's enough from me, Lorianne. But I just want to say, without the public health partnership, from our perspective, none of this would have happened, because we just don't have the expertise. Using that whole of government modelling and approach that we have adopted with this is improving significant outcomes, not just for a service, but for very marginalised and complex group of people who happen to be in prison at that point in time.
Thank you, John, so much for your enthusiasm. It's always a pleasure to work alongside you. And I just want to give a little shout out, in case we're online, to our two public health nutritionists who have helped in this space, Joe Hartley at first, and now Catherine Simpson-Gore, who's leading this work on behalf of Wellbeing SA and alongside John. So thank you, John. I now have the pleasure to introduce Tracy Merlin, who's the interim head of the School of Public Health at the University of Adelaide in South Australia. Thank you, Tracy.
Thanks very much, Lorianne, and John's a hard act to follow, but what I'll be talking about is quite a bit different, because we're a different sort of organisation. So we're a public health partner authority, and we had an agreement with Wellbeing SA from about January 2019, so 3 and a bit years. And the agreement outlines 3 areas of mutual interest that we agreed that together we would like to address. These 3 areas are, the first is on strengthening and supporting the public health workforce to be job ready, essentially. The second was to develop research capacity. And the third was to build an Aboriginal and Torres Strait Islander public health workforce. Now, our main reason for becoming a public health partner authority was simply the desire to work with government to improve the health of the community. So as many of you who are probably on the call know, public health is an applied field, and we're public health experts. We train the future public health workforce, and we wanted to have a mechanism by which we could formally discuss how we might work with government to achieve health for all. Which is something that both of our organisations are passionate about. The decision to apply to be a public health partner authority was a bottom up. We already had people working with Wellbeing SA, and I think Amy mentioned this earlier. It was about relationships that were already existing. We were working, doing research. We had the occasional Wellbeing SA or government staff member give a guest lecture in one of our courses for our students, and both parties thought that this might, having the agreement might be a way to formalise and potentially scale up those relationships that were already there. So I'll just give a quick rundown of where we are to date and how we've managed, how far we've got in addressing these areas of mutual interest. So the first one, which was about strengthening and supporting the public health workforce to be job ready, we've worked with Wellbeing SA to co-design a health systems university course for our postgraduates to try and include more content about advocacy, about policy and soft skills like negotiation. This was because government had indicated that some of the public health professionals that they were hiring didn't have those sorts of skills and those sorts of capacities. So we worked with them to try and incorporate that into this course. That we also co-designed a new Creating Healthy Public Policy course with a focus on learning how to embed health and all approaches into all public policy that impacts on public health. And the course is now in its 2nd year and is really well received by the students. They find it very interesting because it's really applied. It's about, policy and practice. We've also incorporated much stronger public health content into our medicine curriculum. So our medical students are taught about the social determinants of health and are given a much stronger grounding in public health approaches than was previously the case. And Katina very kindly participated in the curriculum advisory group for that piece of work. We strengthened our program of undergraduate and postgraduate student placements. So our students, as part of their work experience component, Wellbeing SA has agreed to supervise them on placement so that they can see what public health is like and health and all policies are like in practice. And so that's been strengthened, and it was kind of timely because what with COVID happening, many of these students who had been on placements in various parts of the department and the government became surge workforce capacity at the height of the pandemic. A number of them were involved in the COVID ops area. They were also involved in outreach programs for communities where there was vaccine hesitancy, particularly in our Indigenous communities and some of our culturally and linguistically diverse communities. So it worked for both. You know, the students got on-the-ground experience about how to deal with a major public health problem in areas which are often disadvantaged and could apply what they've been learning through our teaching on the ground, working with government. A couple of our staff were involved in working groups with Wellbeing SA to develop strategies and identify community contacts in some of these vaccine hesitant communities, and to also set up vaccine clinics on campus. And we're currently working on a strategy for developing public health workforce into the future as well. So that was our first goal. Second goal, which was developing research capacity, we didn't have quite as much going on there yet. I mean, things have been pretty busy with the first goal, but for our second goal, we worked on 2 rapid systematic reviews on the use and evaluation of the effectiveness of community garden programs. And one of our research groups, which is internationally renowned, Better Start, they have a focus on social epidemiology and the early childhood risk factors for poor health. They helped Wellbeing SA address their priority focus on the early years. And they've also worked with Wellbeing SA to deliver professional development and training in epidemiological methods and analysis. And with regard to our third goal, which was building an Aboriginal and Torres Strait Islander public health workforce, we supported a couple of Aboriginal and Torres Strait Islander public health professionals, people who are already working in public health but didn't have the formal qualifications. And so we waived the usual entrance requirements, and we provided them additional support so they can get that happening. We've also identified all undergraduate and postgraduate Indigenous students in our faculty, and we're currently developing a mentoring program to encourage their interest in public health and to hopefully facilitate some of those work placements I was talking about with Wellbeing SA, so that they can, again, see it from both sides. And we've worked with Wardley Paringa. This is recently. Wardley Paringa is the Aboriginal Health Equity Group in the South Australian Health and Medical Research Institute, and we've worked with them to obtain some substantial funding from Rotary for 2 PhD scholarships specifically for Indigenous students to work with Indigenous communities to try and prevent and mitigate the impacts of chronic disease. And those scholarships, this is literally hot off the press, they've just been advertised. So I think there's more work to do. We haven't done it all, completed all yet. We'll be going for quite a while yet, I think. We've made pretty good progress, I think, particularly since it's all happened over COVID. We'll be revisiting our areas of mutual interest at our next steering group committee meeting, which is next month. Part of our agreement at the start was to form a steering group with Wellbeing SA and ourselves as a way to provide oversight and direction for these shared pieces of work that I've talked about. Our steering group meets annually, And these individual projects are allocated to individuals both from within our school and within Wellbeing SA, those people that have got an interest and expertise in the area. And then they meet just as the project requires on a pretty ad hoc basis. The final thing we've done is to create some tools and develop processes to try and streamline our future projects together. We've created a list of experts within our School of Public Health, which we've provided to Wellbeing SA, indicating what areas of expertise they have and that they can be called on if needed for projects that are of interest. And we've also tried to streamline some of the procurement between the two agencies so that if there's a need for urgent research or collaboration in some way, that we can try and do that in a timely manner. And that's it from me. It's been a great opportunity to work with Wellbeing SA on this. We've had high engagement within our school, and with those relationships that we've had with Wellbeing SA have scaled up. It's been really great to see.
Thank you so much, Tracy. And I just want to go back to Tracy and your colleagues and the student support during the COVID vaccine hesitancy work was so invaluable. And again, without that foundation, we couldn't have switched that on as quickly. And we really appreciated your expert advice to make a difference in the state. So thank you so much. Now, Katina and Amy, I don't know if you wanted to add anything into what John and Tracy have already said. And if you do, we'll go and then we'll go into some Q&As before the session ends.
Well, I'm happy to go to Q&As because I realise we're nearly out of time.
Okay, so I'll go back to the questions. I'll go back to the Q&As and start. And as Marianne put in the chat, if we can't answer all your questions at this session, we're more than happy to email them back out and answer them for you as well. So the more questions you put in, we definitely will answer them. We just might not be able to do it now. So I'll go through a few questions, probably around 5 minutes of that. And then I'll pass it over to Horatio to close the session. So I'll go where I left off. And this is an interesting question because it's something we're working on, and I can probably pass it to you, Katina. One of the attendees asked, I would be interested in hearing more about examples with First Nation partners, including governance aspects. Did this involve elders and community leadership? What indicators were developed? And these include reference to traditional knowledge, etc. And I know it's an area we're working on, but maybe Katina, you can go into that a little bit of detail.
Yeah, thank you. Look, it really is it is an area that we have been working on for some time and is still evolving. I will say that there were kind of really critical aspects that needed to be established first, that being an Aboriginal health promotion team, which we now have in place. And equally, the team have established a strategy which is based on strengthening cultural determinants of health. So that is really the platform now where, while we have done some work with Aboriginal community in the health and all policies approach, I would say that really this next period of time with the leadership of our Associate Director of Aboriginal Health Promotion and the team, we will expand. It is part of the strategy and our action plan that partnering with Aboriginal specific services and organisations is the next step. So this will be entirely governed by Aboriginal people. We are also in the process of establishing an Aboriginal advisory group, which will consist of elders within that certainly Ghana elders, but I imagine it will also be slightly broader because Wellbeing SA's remit is across the state. So we certainly take very seriously the need for this to be an Aboriginal-led process, which is why we've taken very kind of careful and planned steps to make sure that Wellbeing SA is in a position now with that Aboriginal leadership to I guess move to that next level.
Thank you so much, Katina. I think my internet's a bit unstable, so if I kind of freeze in a bad pose, apologize, and somebody might want to do the Q&As. I've got a question for you, Tracy. Thank you, Tracy. I would be interested in any links to publicly available information working with Indigenous workforce development, e.g. the 2 PhD scholarships.
I can forward those links to the scholarships, send them through Marianne, or I don't have them right on me right at the moment, but I can grab them. They've been advertised through Rotary Health, and will also be on our website, and through our links will be advertised through our partners and stuff shortly, if not already. But I know they've been advertised through Rotary Health already, so I'm happy to send the link so you can have a look and just see what we're looking for. Yeah.
I'll go, I think one of the questions was already answered. I'll just do one more question and then I'll probably wrap up and go back to Horatio. So the question was, how many public partnership authorities do you have? And we said around 24. The question maybe for Amy or for anyone else in the panel, once these are formulated, do they get funding from the government or other sources, or are they funded through agreements with the partners that they are part of the authority?
Okay, thanks, Lorianne. I'm happy to kick off the answer. So I guess each agreement, each agreement, I suppose, is a little bit different. So I guess there's no general rule that there's any funding attached to any of the agreements. The agreements are more about a commitment of time and staff resources, and of, I guess, content knowledge and expertise. But that being said, a number of our partnerships have included funding or co-funding in particular positions. So like John mentioned earlier, providing funding to embed public health nutrition positions within other government departments, and with one of our other partnerships with local government, we're also co-funding a position there to embed that person into their everyday, I guess, operations, acknowledging that being a different tier of government, the processes and things are different there. And we also wanted that person to really be able to link us as a state government agency with local level partners who have a better understanding of what's happening on the ground. So I guess really in summary, there's no definite rule, but there's no, I guess there's no expectation that any funding would be connected to those partnerships.
Is there anything anyone else would like to add? Or no? Okay, I think there's only a couple more questions, but I know we're running out of time, and I know Horatio wants to wrap up and talk about the next webinar as well. So just again, a huge thanks for people getting up very early in the morning, those in Quebec, staying up a little bit later at night. I can hear my kids doing the dishes, so that's very helpful. And a huge thanks to John, Tracy, Katina, and Amy for everything today. And also huge thanks to the Global Network and Marianne. You're a fantastic secretariat. You were so organized and to get us all here today and keep us on track. So thank you so much. And I'll pass back to Horatio.
First of all, we have challenges. It's wonderful. And I think, thank you for having the same dream of a better life, a better health and well-being for our populations around the world. I want to thank all the speakers for taking the time to participate on this webinar. You certainly provide many insights in how to move health in our policies and multi-sectoral collaboration forward. I also want to thank all those who work behind the scene to make this webinar happen. You know, things when they go well, it's because people work on them. And thank you very much. You will receive a short evaluation from this webinar. Please make sure to complete it because it's an important thing for us. The responses will help guide future global health network health in our policies activities. Also, please mark on your calendar that the Global Health in All Policies Network will be hosting another webinar on November 15 to share Quebec's experience in implementing health in our policies. Promotion from this webinar will start in the coming weeks. Please register at the Global Network Health in Our Policies distribution list to be kept informed. I want to thank you for your participation and stay safe, everyone. We have a lot of challenges, but we must have the dream of being able to make our population in the best situation, working in determinants of health. Thank you, everybody.